Good afternoon, everybody.
Good
Hope
afternoon.
you're doing good. Good. Hey, there's some voices. Okay. Hope everybody is doing well today, and thank you for joining us. We'll go ahead and get started. I've got a feeling that this is going to be a good presentation with some good questions at the end, so want to make sure that we have adequate time to cover everything. So again, welcome everybody. My name is Jerry Newman. I'm your current Northeast NEFHIMA president, and we are bringing to you another one of our Lunch and Learn webinars. So sit back, relax, grab your lunch. I've got Alfredo pasta today, so I hope everybody else has got some good grub too. So just some housekeeping real quick on this. If you can, please mute your phones so that we are able to not have background noise and interference. I'm kind of hesitating to do it myself because I do want people to ask questions. So unless it's an urgent question, though, if you can kind of hold your questions till the end to the Q&A session. We have people still joining. So also, if you are joining just from your phone and you have not put your name in as the person on your phone component of the GoToMeeting, please make sure that you email me to let me know you're here so you can get your CEU event, because you show up as a caller, not as your name if you haven't input your name. So we appreciate that. Otherwise, the video will be released a couple weeks to our YouTube channel if you have any questions. And when I send the CEU form out in the next 48 hours, I will have the presentation attached to it for you for your review as well. So without further ado, we'd like to go ahead and get started by introducing and thanking our speaker today, Barbara Dearmon. Barbara, you're there?
Yes, I am.
So Barbara Dearmon, BS CTR, is the National Cancer Registrars Association, NCRA, immediate past president, and has over 25 plus years of experience working in a community hospital setting, managing cancer registry operations. She received her Bachelor of Science from the University of Phoenix in Healthcare Services in 2009. She is a certified cancer registrar and manager employed by Accession St. Vincent's Riverside in Jacksonville, Florida. Barbara is responsible for maintaining regulatory compliance for reporting cancer incidents to the Department of Health for the health system. In addition, her department is responsible for monitoring compliance with the Commission on Cancer and the National Accreditation of Breast Center accreditations. Barbara is an NCRA mentor, and she's previously served as the NEFHIMA NCRA Education Content Coordinator. She has served as past president of the Florida Cancer Registry Association, FCRA, from 2001-2002, and is the program chair for 2018. She also serves as the FCRA Education Foundation fundraising chair and actively participates in Northeast NEFHIMA student forums promoting the role of cancer registrar. She's written several articles in the FCRA Sun-Times newsletter, NCRA Connection, and Journal of Registry Management membership newsletter. Barbara takes pride in mentoring individuals about the profession, and she currently serves on the HIT Advisory Committee at the St. John's River State College, is self-employed, and assists freestanding facilities maintaining incidents reporting to the state. Everybody, welcome Barbara Dearmon, and Barbara, take it away for me.
Thank you, Jerry. I would like to thank Jerry and Rhonda for the invitation to talk about how to become a cancer registrar. I'm thrilled to be able to talk and promote the profession at large. Let's go ahead and dive into the presentation. Okay. Well, we know that quality data saves lives. The ultimate goal of what we do in the Cancer Registry is to collect data to help support national initiatives to prevent, control, and improve patient outcomes on patients with a diagnosis of cancer. At Ascension St. Vincent's, we have a staff of 5. I oversee Riverside, which includes Mayo Clinic Cancer Center, as well as Southside and our newest hospital, Clay County Hospital in Middleburg. My team accessions approximately 3,500 cases annually. I report to the Director of Oncology, and then I've said previously we have a staff of 6, 5 are certified. We have 1 that's a PRM staff member, and we're grooming her to sit for the CTR exam as of next year. My objectives will be to cover what is a cancer registry, how to become a cancer registrar. We'll discuss a little bit of the National Cancer Register formal education programs, which are accredited programs, and what is the relationship between health information management and the cancer registry. And I will go into a little bit more details on 2018 implementations and changes that has affected the entire cancer surveillance community, from the hospital level to the regulatory standard setters to reporting to the Department of Health. What is a cancer registry? A cancer registry is defined as an information system designed for the collection, management, and analysis of data on persons with a diagnosis of benign, malignant, premalignant, or neoplastic disease. When we talk about benign, we talk about central nervous system tumors. And then when you talk about premalignant conditions, you look at like myelodysplastic syndrome cases, refractory anemia, or myelofibrosis. Information is collected on all patients diagnosed and or treated at our facility. The Cancer Registry data analyst captures a broad range of demographics, diagnostic indicators, treatment information, which is a healthcare institution, hospital, which is St. Vincent. Most hospitals are healthcare-based registries, which we really just collect data on our ministry for the facility on patients treated here. That information is reported up to the central registry as required by law. A population-based registry, which would be Florida Cancer Data Systems, maintains data on a geographical area. And then you got surveillance, epidemiology, and end results, which is SEER. And then you got the National Program of Central Registries, which is mandated by CDC. And those two areas collect data on the entire U.S. population. So the data that we collect is reported up to FCDS. Then FCDS reports their data to NPCR. And then SEER uses that information to tabulate data on United States population. There are several other disease-specific registries out there to maintain particular types of cancers. You got the pediatric, brain tumor, you got trauma, and then you have even birth defect registries. Florida statute public health law requires that any hospital licensed under Chapter 395 and or freestanding radiation therapy center shall report to the Department of Health the following information, which would be the diagnosis of cancer, the stage, the history, the laboratory data, tissue diagnosis, radiation surgery, other methods of diagnosis and treatment at that facility. And of course, failure to comply with this requirement may cause registration or license suspension. We've never gotten to that point, but they will send you a letter if you're behind. The Department of Health will step in, send a letter, and mandate that you get the cases in by a certain time. We also have physician offices are now required to report billing claims to the FCDS by ICD-10 codes, and this is cross-referenced against the state's database. What is a cancer registrar? Well, we're defined as a data information specialist. Our job is to capture a complete history, diagnosis, prognostic indicators, treatment, and health status on every cancer patient in the United States. The data collected provides essential information for researchers, healthcare providers, public health officials to better monitor and advance cancer treatments, conduct research, and improve cancer prevention and screening programs. Cancer registrars, we work closely with physicians, administrators, and healthcare professionals to support the cancer program. We analyze and report data by abstracting cancer incidents into a customized software. The data is uniform coding guidelines. We monitor national treatment guidelines endorsed by the National Quality Forum, and we assist healthcare facilities with maintaining their accreditation for approved cancer programs and regulatory reporting to the state of Florida. We also can assist with recruitment of medical staff. You may, like if it's a disease-specific physician, if he's interested in just doing neurosurgery, we can provide administration data on how many neuro cases come through our campus. On this screen, we'll talk a little bit about how to become a cancer registrar. Formal education is offered by the National Cancer Registrars Association. They have accredited colleges. There's a list of accredited colleges. We'll go over that in more detail. These programs produce excellent cancer registrars. Certification of cancer registrars must meet eligibility routes to ensure quality results. And SEER, which is Surveillance, Epidemiology, and End Results, provide online training modules to cancer registrars. Well, how does the cancer registry relate to HIM? Our case finding for the cancer data analyst to determine reportability is derived from the coding and pathology reports. We get a disease index, which is pulled by ICD-10 codes and CPT codes on a monthly basis. The registry uses the International Classification of Oncology number 3 for coding cancer data. So our case finding is derived from ICD-10, but for coding, we use ICD-03. The cancer registry reviews all cases for reportability. The cancer registry is also required to maintain a non-reportable case log. So if a coder assigns a code of, say, C50, which is breast cancer, which also includes the laterality, which we code separately in our database, will prompt the registrar to review for reportability. If the case is deemed to be non-reportable and found to be a history, we have to track that information. Florida Cancer Data System audits facilities annually when they compare our data against ACA for potential missed cases. So that non-reportable list is typically used to support cases that are not reported to the state, which would normally appear on your audit, and then you would have to respond why the case was not reported to the state of Florida. Professional practice practicum experience. This is designed to provide HIT students with hands-on experience and demonstrate skills in healthcare work environment. The clinical practice on-site visit will provide students with experience in the technical aspects of the cancer registry operations and health information management to complement the knowledge gained during their academic portion of their education. St. Vincent's must have an agreement in place with the local college to allow students to complete his or her professional practicum on site. We work with our volunteer office to conduct the hospital orientation and onboarding process. We have been doing this with St. John's River College in St. Augustine, where we allow the students to come in. I think it's maybe once or twice a year. Probably about 10 students, they'll come in and get hands-on experience in the cancer registry. But as stated, we must have an agreement in place with the college. They have to do onboarding processing through the volunteer's office to be able to conduct that on-site visit. And that's typically collaborated with Health Information Management Department. So they'll spend part of the day learning about the cancer registry, and then the other half of the day they'll spend in the Health Information Management Department. Let's talk a little bit more about the CTR, Certified Tumor Registrar eligibility requirements in order to sit for the CTR exam. You have Route A, Path 1, is successful completion of the associate's degree program for cancer registry management or cancer information management from an NCRA accredited school. Upon completion of that, the student will be required to complete the clinical practicum, a successful completion of 160 hours under the supervision of a certified tumor registrar. Route A, Path 2, is successful completion of a minimum of any associate's degree in any field or equivalent 60 college credits, plus successful completion of the certificate program as well as the clinical practicum. And then you got Route B, is same scenario, successful completion of the minimum of an associate's degree in any field, 60 equivalent college credits, must complete 2 semesters of anatomy, human anatomy, and physiology, plus 1,950 hours on the job, which is equal to 1 year full-time. Most students will come in via Route A. Path 2 is the most common route. There are some challenges with getting the 160 hours, but we'll talk a little bit more about that, what NCRA has implemented to help students complete some of their hours virtually online. The Certified Tumor Registrar credentials demonstrates the knowledge and professional competence needed within the Cancer Registry. It is nationally recognized in recruitment and retention. NCRA's board certification, the Council on Certification, develops and administers the CTR exam. And we have approximately over 5,000 individuals who have already obtained their CTR credentials. Hospitals accredited by Commission on Cancer require that all abstracting be performed by a CTR. Hospitals have the option of hiring students or staff members that are CTR eligible, but that individual will be required to obtain their credentialing 2 years from date of hire. You can go to the CTR exam website to learn more about the exam and download the current CTR exam handbook and application. NCRA offers the exam 3 times a year, and details on the exams and application and deadlines and locations can be found on the website. Here's a list of associate degree programs. Majority of the programs are offered online, but some of them can be attended on site. I know Santa Barbara is on site. Southwest Wisconsin Technical School, I believe, is also on site. So some of them have a combination of where you can do the class on site or online. So this is your associate degree program. And this is the list of your certificate programs that are available. And these are all listed on NCRA website. Now, the most common certificate program that people will opt to complete is the American Health Information Management, the AHIMA program. The AHIMA program is administered by AHIMA, but managed by NCRA. So NCRA takes charge of this one, and they maintain all the curriculum for this particular program, certificate program. I'm going to go over a few facts about the NCRA accredited program. The program selection depends on your own educational background. The length of time to complete the program depends on whether a student is enrolled in a program through a college or working in a self-directed online program. The length of time to complete depends on the student. Successful completion of the NCRA accredited program will result only in a certificate or degree, but not the CTR credential. To gain the CTR credential, a candidate must apply and pass for the CTR exam. So taking formal education will equip you to sit for the exam, but it does not guarantee you your CTR credentials. Cancer Registry definition. For eligibility purposes, to sit for the exam, the Council on Certification defines the Cancer Registry field as the collection, management, and analysis of cancer incidence data for all the following purposes: for research, quality management improvement, cancer program development, cancer prevention and surveillance, survival and outcome data, compliance of reporting standards, and development of accreditation standards for cancer registration. A well-prepared candidate experience within the last 5 years should include all the basic aspects of the cancer registry, including but not limited to case finding, abstracting follow-up, reporting, cancer committee and cancer conferences, as well as NCDB. The rules in the cancer registry are changing so frequently. We recommend that if you're going to sit for the exam, you should do it with being active in the registry at least within the last 3 to 5 years. I would say 3 years. 5 years is expanding it because the guidelines are changing rapidly as we speak. So you got to stay abreast of all the changes if you're going to sit for the exam. Some of the prerequisites required for the NCRA accredited program include computers and healthcare, human anatomy and physiology 1, human anatomy 2, and medical terminology. For anatomy and physiology, a college level and a minimum of 3 credits is required, and a passing grade of a C to meet the prerequisite is required for the NCRA AHIMA CRM certificate program. You will be required to take 3 credit college level courses in computers and healthcare and earn a C or better in order to complete the prerequisite requirement. The 160-hour clinical practicum, NCRA accredited formal education programs require students to complete a 160-hour clinical practicum for 2 of the routes. The clinical practicum is a critical component of a cancer registry training, but finding a facility practicum can be challenging. And even when a facility is found, oftentimes not all required clinical activities can be completed on site. So this is why NCRA has implemented the Independent Clinical Advisory Group, and we'll talk a little bit more about that. So the Independent Clinical Advisory Program is virtual clinical practicum. This is where students can sign up to complete part of their 160 clinical practicum online. They can abstract 15 cases to obtain 30 hours. Students can complete 15 of the 30 required abstracts online through SEER Educate, which is an online platform, as well as doing case finding on SEER Educate, which you can obtain 9 hours. And students can complete the HIPAA course, which is a 3 hours, to also obtain some hours for doing the clinical practicum. So that's approximately about maybe 60 to 70 hours that can be obtained online, and then they would have to work with the hospital to complete their other part of their clinical practicum. There's several types of opportunities in the cancer registry profession. The most common is hospital institution, or software vendors, the ones who write up the programs in order for the registry to collect your data. You got your government agencies, which is the National Program of Central Registries, the Center for Disease Control and Prevention, SEER Epidemiology and End Results. You got your regulatory agencies, which is Florida Cancer Data System, Commission on Cancer, the National Cancer Institute, and also the National Association of Central Cancer Registries, who establishes the data dictionary for collecting cancer data. You got pharmaceutical companies, you got outsourcing services, independent contractors, and working in a research setting. So there's ample amount of opportunities in the cancer registry. I'm going to switch gears and talk a little bit about 2018 implementations and coding changes in the cancer registry profession across the nation. So in 2018, there was approximately 8 new rules implemented. We have the SEER summary stage. 2018 was updated, which had not been updated since 2005. Then you got the multiple primary and histology rules and solid tumor rules. So they have rules for every primary site on determining how many primaries it is, and what is the correct code for applying the histology. You got the American Joint Commission on Cancer Staging Edition, which was released also, which is now anatomic and prognostic staging. So you just cannot stage a patient based on surgical resection. You have to have the biomarkers in addition to the surgery in order to stage the case. We're now capturing 3 different fields for coding the grade. You got clinical grade, pathologic, and post-grade. Post-grade would be a patient post-neoadjuvant therapy that go and have surgery, so that grade is also being captured. ICD-03, which we talked about earlier, is what cancer registries use to code histologies, the topography, and behavior codes. Well, this book has not been updated for several years, but they've made several changes on histology codes, which are now online. So the purple book, which we call it, is outdated. So registrars should not be using the purple book. They need to be referring to all online resources. You got the site-specific data items, which are your prognostic indicators. When we talk about prognostic indicators, we're talking about tumor markers, your CEA, your ER, PR, your HER2, K67. Those are all prognostic indicators for different specific cancers. You got the extent of disease, which determines how far the cancer has spread it to an organ, which is new. And then you got your hematopoietic and lymphoid neoplasms. So any patient that comes in with myelodysplastic syndrome, lymphoma, leukemia, myeloma, you have to use a separate website to code those particular cases. So my team is in and out of maybe 6 different applications in a given day just for coding the rules. And this is just a screenshot of how changes impact the cancer registry. NACER is responsible for establishing the record layout for the cases, the core data items to be collected, and the data dictionary rules. The data dictionary tells why the data item is required and how it should be captured, how many fields is valid, and how to code it. SEER, Epidemiology and Results, uses the information. Then we have CDC, which is the Center for Disease Control and Prevention, the National Program of Central Registries, and Florida Cancer Data System. Those work together collaboratively. CDC oversees state reporting and then all central registries. Then if you come down here, you got Commission on Cancer, American Joint Committee on Cancer, and then the National Accreditation of Breast Centers. So those are some of your accrediting bodies that regulate hospital accredited programs. Then you have the National Cancer Registrars Association, which sits on majority, I think we sit on all of these committees when it comes to implementing new data items to be collected so that we can have a voice for the cancer registry. And then finally, the cancer registrar is the one that starts the data collection. So you got the standard setters set the rules, and then it is relayed up to the cancer registrar to collect the information. So we talked a little bit about the AJCC staging that was implemented. The book was dedicated to cancer registrars. This is the gold standard to help with the cancer patient management, and helps physicians to determine the correct stage for patients, allowing for the most appropriate cancer care. There was 12 new staging systems added, and as you can see, it's anatomic and prognostic staging. This is just an example of breast cancer staging. You got the anatomic stage table, which is the tumor, nodal and distant metastasis, which is the extent of the tumor. You got clinical prognostic staging, which is the clinical stage, the H&P, imaging and biopsy. And then we have the prognostic portion of it, which includes surgery and biomarkers, and then the stage grouping. But if you look at where it says T&M, you assign this first. You have to apply the grade. then you have to apply if the HER2 was either negative or positive, as well as the PR status, in order to assign this grouping. So in the past, you didn't need all of this to assign a stage. So now, in order for any of my team to assign a stage to a patient, we have to have all of this information in the chart. Surveillance epidemiology and end result educational resources are available for coding 2018 cases. This is a new platform called Registry Staging Assistant, which provides some of the new data items for coding. They oversee the extent of disease fields, SEER summary staging, site-specific data items, and coding the grade. So the registrars can go to this link, site-specific, to look for cases for the information for coding all those new fields. And once they enter the application, this is what comes up. If they click right here, this is the schema for every primary cancer site, and it tells them how to code each one of these fields accordingly, and there's a drop down with different codes to select. SEER summary stage is basically the old staging, where it talks about whether the tumor is local, regional, or regional direct extension, if regional lymph nodes are involved, if it's both direct extension and then lymph node involvement, distant metastasis. You even have a code for borderline tumors or benign tumors, and unknown if it's staged. So this was the only thing we had probably when I first started in the registry 30 years ago, but over the last 15 to 20 years, they've implemented additional ways for staging cases. So jointly, what they do is they derive the best stage based on the SEER summary stage, the extent of disease, the T&M staging. So they develop the best stage based on all those fields that are coded. STORS is the Standards for Oncology Registry entry, which replaced the Faculty Oncology Registry Data Standards, which was the old manual for cancer registry staging. This is only for accredited programs. So some data items that were required to be captured were discontinued, and new data items were implemented for capturing sentinel lymph node biopsies, AJC staging, collaborative staging discontinued. So there's a whole bunch of new data items that are required. Here's a list of some of them. You got your new radiation data items are captured in phases now. You have to code based on phase 1, 2, and 3. New sentinel lymph node data items have been added for breast and melanoma. And then you also have to capture the date that the lymph node dissection was done for the sentinel lymph node exams if they were positive or negative. Then we have Florida Cancer Data Systems. They updated their manual as well. Florida Cancer Data System has decided not to capture the AJCC staging due to all the delays with software upgrades, and has extended our deadline until March of 2020, and will require only for registries to report to them the EOD, which is the extent of disease, the site-specific data items, the grade, the new radiation data items, and etc. So the cancer registry normally would be closing out cases in June, but due to all the delays with all the implementations, they've extended the deadline until March to get all the cases in. So we're still abstracting June of 2018 cases when we should be finishing 2018 cases in June. So that just goes to show you how much of an impact all the 2018 changes has affected the cancer registry. The Commission on Cancer Radiation, new data items, we just discussed that. The new phases that are coded by the abstractors involves external beam planning technique, treating the primary volume, treating the draining lymph nodes, and then treating the primary modality. Genetics Plus is an application that we utilize to check for accuracy or discrepancies with the coding. If you look at this particular screen, it's just showing you that um, that is invalid, what's invalid in the field. So we have several applications in place to go back and validate what's been coded or what's incorrect. So prior to submitting our cases to the state of Florida, as well as the National Cancer Database, this is a free application that's provided to all COC programs to upload your cases and then validate the accuracy of the data being reported. Here's just another screenshot of some of the edits that it's looking at. It even looks at the demographics for accuracy. It looks at regional lymph nodes if they were examined or positive, serosum restaging, the TNM addition, and then the data diagnosis. So there's a lot of QC on our cases. There's a wealth of information on 2018 training. These are all the different organizations that are offering training, still ongoing training with 2018 implementations. 2018 implementations has been challenging. It has impacted reporting cancer incidents to the state. It has caused major delays with just capturing the data. Education and training has been required to adapt to the rules. NCRA is providing education on new rules to the membership. You got software and vendor delays. It has impacted the entire cancer surveillance community. And then not all changes were released at the same time. And then the record layout was not even released at the same time. And we've already discussed that the Central Registry is extending their deadline for reporting cancer incidents to the state of Florida. And then this is just a slide that your members can look at. It talks about the value of cancer registries and how it helps the CDC measure progress on monitoring cancer control throughout the United States. And I'm going to open it up for any questions.
Does anybody have any questions? Any of our students online, or I mean, I know that I remember when I was in my classes, kind of lead off here with this, you know, I took the SEER training modules as a part of my classes. I don't know if that's still standard as part of the HIM program, but how often do they update that training, and, you know, exactly how does that, taking some of those little online modules, assist and aid if you aren't going through a direct Cancer Registry tumor program?
Well, I know for a fact that all the programs will have to update their content, their course content, to reflect all the changes for 2018, because students, individuals are already being tested on some of the changes that have been implemented. So the formal education programs, whether it be the degree program or the certificate program, will be required to go in and update that course content as required. I know NCRA manages the NEFHIMA content, so they will be responsible for going in there and updating that information. Did that answer your question?
That did, thank you. I'm trying to think of a few other things here because I know there's some thoughts running around. Does anybody else have any thoughts or comments? Any things that you'd like to have clarified?
I do. What's the best, I guess, course of action for a new graduate? I'm currently in the HIT program, and so if this is a career I'm looking to pursue, other than taking the necessary courses, what's the best way to, I guess, get your foot in the door?
I would say the best way to do it is to start. Now, if you don't want to do formal education and you just want to volunteer, you could check with the facility to see if they're accepting some volunteers to volunteer in the department. But if your goal is to pursue a career in in the cancer registry profession, I would say do your formal education first, then reach out to a hospital to see if you can do your hours. Another thing too is most people, I also strongly recommend reach out and get a mentor. Get someone that's already working in the field that can help you to achieve the goal that you're trying to achieve. Having a mentor is strongly recommended.
Thank you.
You're welcome.
To piggyback off of that thought, are there any positions, entry level or otherwise, such as coding positions or whatnot, that may help a student or an established professional find an avenue into that while they pursue educational?
Well, like I said, that if they're CTR eligible, some organizations will hire them and bring them in doing, maybe entry level work before they can get to where they need to be. Now, here at St. Vincent's, I don't have no entry level positions. It's either all are certified or you're not. So if I have a PRN staff member that we hired her as a cancer data analyst, so my goal is to train her to become certified 2 years from date of hire. So she's already abstracting, she's already doing case finding, she's already attended cancer conferences, she's already attended cancer committee meetings. So she's getting all that hands-on knowledge to prepare her to take that CTR exam. You will have some entry-level positions, maybe at bigger institutions where say someone may only need to do follow-up, or someone that's just only doing a cancer conference coordinator or a cancer committee coordinator. We're a smaller hospital, so we only have a staff of 5. But if you're working at an academic institution, they may have more entry-level positions than your typical hospital. If you're going to work in a hospital, I tell people all the time that you're going to be multitasking. You're not going to just be doing one job. So I'm not going to just hire you just to do abstracting. A lot of the work that we do is shared responsibilities. So we share the responsibility when we're doing patient follow-up. We share the responsibility when we're doing abstracting, and sometimes even when they're doing case finding, as well as cancer conferences. So does that answer the question about entry level?
Yes. Yeah. Okay. Some good thoughts there. I have a question online from Tricia Bailey. It says, I am currently in an HIT program. Do I need to study him before becoming a cancer registrar?
Say that question. So she's currently, has she completed her HIT program?
Well, it says I'm currently in an HIT program, so I don't believe completed. So she's just...
Yeah, so what I would do, what I would say to that, I would say finish off your HIT program first, then pursue the formal education into cancer information management. So I often tell students when I go talk at a college that, although you've just successfully completed your HIT program, unfortunately, you're going to have to get formal education in the cancer registry management portion of it. So if she finishes the RHIT program, she already has probably anatomy and physiology and medical terminology up under her wing. So really all she would have to do is the core courses in cancer information management.
Okay. Excellent. Tricia, I hope that answers your...
Oh, go ahead.
No, go ahead. Complete your question.
My question was, do you think that for folks who maybe have a coding background are more sought after transitioning to a cancer tumor registrar?
You do have a lot of the cancer registry membership is very diverse. You have nurses, you have HIT professionals, you have coders, you have researchers. So you have all different people that migrate into the cancer registry. A lot of them have migrate into the registry as a second career path. I just happened to start it as a baby. But I'm still in it. But yes and no. You know, you got people that have coding background. And if you do have a strong coding background, that may help you to migrate into the cancer registry, you know, with your coding knowledge base, because the cases are derived from ICD-10 coding, but it's coded differently in our database because we have all these different rules that you have to utilize when capturing the cancer data within the cancer registry.
Okay.
Thank you.
You're welcome.
I have another question. Jenna Barr, I believe, is one of our members and a student up in the Jacksonville area, perhaps at St. John's, and she was curious if we're students in the HIT program, are we still able to come to your site to volunteer or do externship hours, even though we're not in the program specifically as a cancer registrar?
Okay, so we're not official. St. Vincent's is not is not known as a NCRA clinical site. Okay, but we can take students if they go through our volunteers department and they assign the volunteer to us to do hours. But what I recommend, I think I just had a student from St. John's College, Stacy, I think was her name. She was interested in the cancer registry. She did her 60 hours for her clinical practicum for the HIT program in the cancer registry. But I advised her that if you're going to pursue the cancer registry, then you really need to do your formal education first. And then once you do your formal education, then we can take what you've learned in school academically and then apply it to the virtual training. So the answer is yes, students can still volunteer to get their hours, but me, for my professional experience and my knowledge base, I would recommend that a student do their formal education first before they do the online or volunteering, because it's going to take a lot of time to train someone from scratch if they have none of that knowledge base.
Okay, thank you on that. So a thought I had here with this is you obviously, you said you have a nice little thing set up with St. John's Rivers College for that. Are there other schools or other locations that you might be aware of in the state that are doing similar programs like that?
Like what we're doing with the professional practice practicum?
Correct.
I've recently reached out to FSCJ. So we have students from the North Campus that have been coming over. They've visited with us, I think maybe twice so far, because St. Vincent's has an agreement in place with the college. So really would have to be coordinated with myself, the volunteers department, and Rhonda, the HIM manager here. So it's like all three of us have to coordinate our schedules to make sure all of us are available in order for the students to tour on site. So right now, the only two that I know that's doing it, the only two that I've done it with, and I've been doing it with St. John's College for the past 5 years, and FSCJ within the last year, we've been doing the professional practicum experience.
All right. And any other questions out there?
I have one. If we're currently getting our AS degree in HIT, do you recommend we also get the associates in CTR or just the certificate?
I would say just a certificate.
Okay, thank you.
Yeah, you're welcome, because you can do the certificate program because you already have a degree. I would recommend the certificate, and then after you complete the certificate and the 160-hour practicum, then you're equipped to sit for the CTR exam.
So I have kind of two questions here.
Sure.
We've talked a lot about the students here with this, but what if you have a seasoned professional who's done coding, who's been abstracting, who's been involved in quality, maybe has done clinical work, anything in that area, working offices.
Mm-hmm.
And they're wanting to perhaps take a step down or a change in path or anything like that.
Mm-hmm.
It's been a while since they've been in school.
Mm-hmm.
Are they looking at potentially having to start all over with this AS or the certificate program, or is there any kind of credit given for those past experience and for the past education?
No grandfathering. No grandfathering. And that was a real hot topic when they made it where students had to have a degree in order to sit for the CTR exam. There was no grandfathering. So what they did is they phased it in over like a five-year span. So by a certain time, when Commissioner on Cancer came back and said, this is law, you didn't have a choice. And they have it now where you can't even, like if I have someone here working in my department and has been working more than 3 years and is not certified, they're not allowed to abstract. Okay, so they have to get those credentials. I would say someone that's seasoned like that, with a lot of knowledge, ready for career path change, I would say go for the certificate program. Find a hospital to do some on-site hours, get a mentor, and then prepare yourself to sit for the exam. It's doable because a lot of people change career paths. I'm constantly getting where people will call me and say that they're interested in doing something different. They could be in nursing. Been a nurse all these years, now want to step down, want to do something just a little bit less.
Excellent. And my last question that I have, and I'll release it back to everybody else if they should have any questions. My thought is there's a lot of changes, a lot of implementation changes, a lot of cross-referencing that you have to do. I would think that you're already talking about being a little bit behind. So how does that potentially impact future growth within the field, as far as, is there a deficit of tumor registrars, and what kind of a need is out there right now as we move forward?
Great question. A lot of the what has been challenging over the years is that we have a lot of baby boomers. So you got a lot of people retiring, but not a lot of people replacing the ones that are retiring. Okay, so there's positions out there that's available, but at the same time that the changes are being rapidly rolled out, education is essential. So I push education at my institution for my team to participate in educational activities, not just once a year, but whenever there's free education out there that's being offered by the state, the government, or the vendor, my goal is to make sure that my team is actively participating in those educational activities so that they have the skills and that they're well equipped to deal with the changes, to be able to apply them real time with data collection. So that's the answer to that. Yes, the changes are rolling out and are coming out rapidly, but it's really up to each institution to make sure that their staff has the tools and resources that they need to adapt to all those changes that are being rolled out.
Thank you. All right. Well, as we start winding down here, we are almost out of time. Is there any other questions out there? This has been a great Q&A session.
Thank you. And I've enjoyed, and I appreciate you giving me the opportunity to talk a little bit more about the Cancer Registry. And if you're interested in learning more about how we do the professional practice experience, just reach out to me and I can send you some information on it.
That's great. All right. Well, do we have any last questions? All right. Well, I really appreciate everybody being in attendance today. Again, if you were on under your phone and you don't have a name inserted, you show up as a caller 02 or a caller 03. Please make sure that you've let me know that you're here so I can give you credit to get your CEUs. The evaluation link and CEU form along with today's presentation will be sent out within the next couple of days. And as Ms. Barbara said, if you have any questions, we'd be happy to pass them on to her and get you some individuals. But in the meantime, everybody have a great afternoon, and thank you for joining us today for our Lunch and Learn.
Thank you, Jerry. Y'all have a wonderful day. Bye-bye.
Thank you.
Thanks.